Hello and welcome to Pulse Check with Archer Nursing, where nursing comes to life. In this podcast, you give us 15 minutes of your day, and we'll take one complicated nursing topic and make it easy. Ready for nursing to be fun? I'm Morgan, and today we're coming to you with a bonus episode to talk all things collaboration between nurses and physicians. Here with me is Dr. Stephen DeMeo. Welcome, Dr. DeMeo.
Hi, Morgan.
Hi, Dr. DeMeo is a neonatologist and the chief medical officer here at Archer. He completed his residency in pediatrics at Al DuPont Hospital for Children in Wilmington, Delaware, and then went on to a neonatology fellowship at Duke University. He also completed a master's in medical education leadership, and now, as his role as my counterpart, CMO at Archer, Dr. DeMeo sets the medical and academic vision, oversees all medical content and curriculum development, and serves as our principal external voice to learners, institutional partners, and the broader healthcare community. So welcome to Pulse Check. We're so happy you're here today.
Thanks, Morgan. I'm excited. This is my first appearance on Pulse Check. I'm sure it's going to be one of many, but it's good to be talking to you today.
Yes, we're going to have a whole series. So starting us off, we're here today to talk about MD, RN, collaboration, communication, all those things. And when we talked, what are we going to do for this first episode together, we thought this would be timely, a good episode to discuss now. As we're recording this, we're going into the beginning of July. And most of us know we've got a ton of new healthcare professionals, both MDs, RNs, and everyone in between, that tend to start right around this time. So with all that being said, I think at least for me, Dr. DeMeo, you can chime in here. Interdisciplinary communication collaboration, that's kind of a piece of our work that we don't necessarily get like formal classes and training on. At least I didn't. And it was intimidating, to be honest. You're going into a new workplace. You don't necessarily know people. So I just want to set the stage with like, why does this matter? And that opens me to my first question for you. Tell us what happens when nurses and doctors work with each other instead of just around each other. What's like our best outcome? What do you see?
Yeah, that's what we're aiming for, right? Because when that relationship is working well, it's when patients ultimately have the best care. And you're right, this is an exciting time of year in most healthcare systems. There's a lot of new nursing grads, there's a lot of new APP grads, and of course, our new residents and fellows are getting started. Sometimes in completely new programs, sometimes in their first role right out of medical school. And of course, a lot of new attendings are starting as well. And that brings with it a whole host of learning opportunities. So definitely a timely topic. I think when I think about the nurse-physician relationship working well, it's having team-based care that's aligned to the needs of the patient and getting them care that is not reactive, but proactive. So a team in alignment with understanding, in my case, inpatient medicine, what are the goals that need to be satisfied during this hospitalization? What are the barriers to discharge? What are the acute issues versus chronic issues? And ultimately, how is communication going between the care team? Yeah. And when we get into that proactive rather than reactive mode, I think you end up with a healthcare team that ends up working well with hopefully a little less stress and ultimately better patient outcomes.
Yeah, it's like less putting out fires and more saying where are those fires potentially going to pop up so that we can at least talk. I mean, maybe they will even if we do everything right. We know that's the nature, especially of intensive care medicine. But can we anticipate where they might come? I think for me, something big is, since I'm typically at the bedside with the patient, the client, and their family, is if we have that really tight interdisciplinary communication collaboration, I think the family ends up feeling more included in their care. And a big call out is they end up not having to repeat themselves as much. I have seen families who have to tell their whole story of this, that, and the other over and over every time a new nurse comes on, every time the doctor hands off care. And that gets to be tiring, frustrating. It's just exhausting. So I think when we really tie that teamwork together, that's just one concrete outcome of the family's like, I'm included. They know what's going on here.
Yeah, can you imagine if you've started your journey into the hospital being admitted through the emergency department, imagine how many times you've had to tell that story of what brings you in. Now there's pros and cons to that, right? Having healthcare providers ask similar questions is actually sometimes helpful in preventing that diagnostic inertia where we label a patient with one diagnosis and we all just keep repeating that to ourselves and it turns out, it's a wrong diagnosis or a misdiagnosis. But I agree with you. I think any opportunity for our patients and families to see the nursing and physician team and APP team as one,
Right.
and not different entities, the better. So I always use interdisciplinary rounds as a good example.
Mhm.
I think, we always make this joke about rounds take so long.
Mhm.
I can't stand here in front of this computer for 3 hours. But what I always try to teach interns is if you run interdisciplinary rounds well and the nurse is involved and the nurse can speak up and respiratory therapy can speak up and the family can speak up,
Yep.
think about all that time that saves you on the back end, all those pages and phone calls during the day about someone doesn't understand the care plan, someone's confused about what's going on. And if you invest that time with the team together up front, I think it saves a lot of unnecessary interruptions to what ends up being an impossibly busy day for everybody, both nursing and physicians and APPs on the back end of the day. So I hope everybody's norms are interdisciplinary rounds
Yeah.
where they work, but if not, I always try to model for our medical students and residents that having the nurse not only there, it's more than just presence.
Yeah.
It's creating an environment where they're empowered to speak up and empowered to
Mhm.
share what their thoughts, concerns, questions are, and being comfortable doing that in front of the patient that ultimately ends up getting us to better patient care.
Oh, absolutely. Okay, you brought up two things that I want to ask you about. First, being there can sometimes, not for everybody, I don't want to overgeneralize, but I'll speak for my own experience as a new nurse that knew I had a lot to learn. There was definitely a fear of I'm going to bother the doctor. I'm going to step on toes. I don't know if this is really concerning, so I'm not going to send that page. I'm not going to go find them yet. To me, that's when communication behind the scenes kind of breaks down and the care team isn't functioning as well. So, talk to us a little bit about that perception from your end as the doctor getting probably a lot of pages. I mean, sometimes you are getting bothered.
Yeah. And my answer changes based on, where we've met each
Mhm.
other at this stage in my career. So it's very different as an attending than probably it was as an intern or resident, where I think in a good way, the barrier between nurses and residents is maybe a little less in that the hierarchy is a little bit different. But you're right. There is certainly still this perception that persists potentially from new nurses that they're bothering the physician or that the idea of communicating with the physician is intimidating.
Mhm.
And so there's a couple things I've tried to do that get at that. The first is just open communication at the get-go with your nursing staff. Now, I have the luxury of working in what you'd think of as a closed unit, right? I'm only in the neonatal ICU.
Okay.
We get to know those nurses over time. It's not like I'm bouncing between different units in the hospital.
Yeah.
But what I try to set up is an environment where I will say out loud that I expect you as a nurse to tell me when something doesn't make sense, you have a question or you're concerned about something about the patient's condition. And sometimes just naming that lowers the bar for nurses to say, like, okay, he literally gave me permission to do this, so therefore
Yeah.
I'm not going to hesitate.
Yeah.
The
The
other thing that I've
expectation.
seen,
I like that language. Like
yeah,
Dr.
just say
DeMeo
it.
expects this. Like, I'm going to do it. Yeah.
Correct. The other thing that I've seen that's really nice about NICUs I've worked in is the way in which nurses can support each other with maybe that first line question. So I've seen new nurses have that buddy who's more experienced nurse to say, hey, I noticed this vital sign change or this.
Mhm.
What would you do? Or how would you approach this?
Mhm.
And a lot of times I've gotten feedback that it was still a good question, but it was one that was handled kind of at the nursing level. There was some filtering done, or maybe there was agreement that, like, actually your instinct is right, that needs to go to the NMP or that has to go to
Yeah.
the physician, let's contact them now. And so in general I would say that whether I'm on call or whether I'm just on service in the unit,
Yeah.
the chance of me getting upset about you contacting me about something and it being nothing versus you sitting on something that ultimately was important or caused an issue with the patient, I would much rather be called and have it turn out to be nothing.
Mhm.
Here's my caveat to that for new nurses. The thing that frustrates me is when the call happens without the information or the details behind it.
Okay, that's
So,
good.
like calling a bilirubin result without the context of what's the patient's age? Do they have risk factors for hyperbilirubinemia? Have we looked at bilirubins before? What's the trend? That simply calling to report something without the context of what it means to the patient care. Or if I have a secondary question, like how old is this patient? Does this patient have ABO incompatibility? And the nurse doesn't know those questions, it can delay the helpfulness that I can bring to the situation. So again, not in an intimidating way, but I think when you're getting ready to make that call, just have your ducks in the row. You've got, depending on acuity in the ICU, it could be a one-on-one patient, could be a 1-to-3. I know there's probably some med surg nurses that are saying 1-to-3. That sounds fantastic. I wish I
That's
had
on
that
the
nursing
luxury
ratio.
vacation right
But
there, 1-to-3.
just remember that, yeah, on call, I'm responsible for, sometimes up to 70 babies across 3 units. So the minutia about your patient for the most part to a degree that I'm not going to have for every patient. So I actually really depend on you to have that background information as we're assessing what a patient needs next.
I love it. A few takeaways I got from that. Number one, your physician expects that communication, so don't get that mindset of hey, I'm bothering them. Number two, use your resources around you. I say all the time, nursing is a team sport. You are not the only nurse in the unit. If you're brand new, you potentially have a preceptor that should be helping you guide through this, but we all know the learning doesn't stop once you're off that orientation and you don't have that preceptor anymore. Sometimes that's the phase that's most intimidating because they might have been handling some communication that now you're responsible for. But just because
Yeah.
you don't have a preceptor doesn't mean you can't tap into the knowledge of everyone else around you. So kind of filtering, like Dr. DeMeo said, hey, what would you do about that? That might also prompt you to ask yourself some of the why questions. So before you go, okay, I'm just going to page Dr. DeMeo about this, ask yourself why, fill in the blanks, get your ducks in a row, like we said, and you're going to learn from it. There are going to be situations where the doctor asks you a question that you didn't anticipate. You didn't think about the risk factors, the ABO incompatibility. And that's going to stick with you. You're going to tuck that knowledge away and say, next time I need to think about this, this, and this. It's all a learning opportunity, and that doesn't mean it's not going to be hard. But if we frame it that way and know there's that expectation, it can be a little less of, hey, this is going to be a barrier to communication, and more, this is going to be a step along in my journey.
Yeah, and I think you brought up the second piece of intentional communication that's important for physicians to think about is naming the reason why you're giving the nurse the feedback on why those pieces of information are important. So if you simply go into that like, I can't believe you don't know these things about your patient. This is useless. I got to come over there. What's going on? That's not helpful to anyone. But if you explain to a nurse, the reason I'm asking you is because if the answer to this question is yes, this is going to take us down this road versus this road, then you're actually educating and you're going to make that nurse better the next time that situation comes up. And so we try to take the opportunity, and it's hard when it's 2 a.m. and you're tired.
Sure.
It can be hard to go that little extra step, but I think just that extra step of like, this is why I'm asking this is what I'm thinking is really important. Now, my one caveat to this is for the interns and residents. I just told you that specific information from the nurse is really critical. There's one exception to that, and that's the nurse that calls you and says, Dr. DeMeo, I need you to come to room 23 as soon as possible. I just have a feeling that something's not right with my patient. So there is this phenomenon in nursing, which is like the nurse gut feeling about patient deterioration. And Morgan, we have to go find this paper because someone actually published on this.
Oh, wow.
The validity of the nurse feels something's off call. And when that turns out to be real pathology, someone tried to study this. If you're a brand new intern and a nurse, especially an experienced nurse, and I can name those nurses in my life that I can think of where this happened, and they call you and say, I need you to come to room 10, room 11, whatever, because I'm really worried about so-and-so. I've had this patient since he or she was born and something is not right. You get your boots on and you go there as soon as possible. Here's why. At worst case, you get there, you do an evaluation, and you determine collaboratively with the nurse that actually everything is okay. And then you've had a chance to see your patient, do a physical exam, check some labs, and you've probably learned something. Best case scenario, that nurse just saved a patient's life. And that's literally happened at times where that nurse inkling that something doesn't feel right
Yeah.
has been the early warning sign of something like necrotizing enterocolitis
Mhm.
or a pneumothorax or
Mhm.
congenital heart disease. So interns, July's coming up. If you get that page, take the time to go evaluate that patient because there's a high likelihood that that nurse's instinct is right.
Yeah, I'm so glad you brought that up. And I'm definitely going to go dig that paper up and find that somewhere because it's one of those things that it takes us a little while as a nurse to start trusting our gut. But here's some empiric evidence to say, yes, you do know this patient, this baby, this client the best. You are at the bedside. You are seeing tiny little things. And sometimes it can be really hard to put your finger on that. Dr. DeMeo, I actually have a next story very specific to what you were just talking about, where vitals hadn't changed yet, labs hadn't changed yet. All shift, the baby was just like cranky, just not acting like the baby had been acting for the past however many shifts I had had the baby. Nothing else, though, like their abdominal girth was fine, their belly was soft, like nothing else was jumping out. I couldn't think of a reason to say we need to get an x-ray. But we did, and there was neck. They just hadn't shown up on labs and all of that other stuff yet. Do you have any stories you want to share? Anytime a nurse has communicated something that changed your decision making, maybe prevented a bad outcome? Anything you've got?
Yeah, absolutely. I'm thinking of a situation actually in residency when I was in the pediatric emergency department, and it was during the H1N1 pandemic. And so, for those who don't remember, around 2009-ish, we had a H1N1 outbreak in the United States, which was leading to many, many sick kids seeking emergency care. Thankfully, it wasn't translating to hospitalizations, just a lot of fever, cough. But it got to the point where a lot of our emergency departments in the Philadelphia area were overwhelmed. And I was on emergency medicine that month. And one of the things that can happen is medicine is, especially in pediatrics during viral respiratory season, is you get beaten into submission by seeing the same thing over and over and over and over again until the next thing you see is not that disease that everyone else has, but it's the mimic of that disease. So I was in the middle of a 8 or 10 hour emergency medicine shift. And again, we had nurses doing triage out in the parking lot because hundreds and hundreds of children were coming to the emergency department with H1N1 flu. And one of the intakes was a teenage girl, same presenting symptoms, but the nurse and I just assumed. I remember prejudging in my head. I saw it pop up on the board. I saw the complaints, and I thought, "Here we go. This is just going to be H1N1. She's going to be fine. Like let's
Yeah.
get this done. Let's get this
Let's do
bed freed
this.
up. Let's
Let's
get
move
out
on.
of
Yeah.
here." The nurse, because we created an environment at DuPont where there was good working relationship with residents and fellows and the attendings modeled that for us as new trainees.
Mm-hmm.
That nurse marched into the workroom and she was like, "Who's got this bed?" And like, "It's me." And she's like, I think something's wrong. I need you to come right now." And I got up and I'm auscultating and I hear like no breath sounds in on the left side. And I'm like, "All right, I think this is probably just H1N1, but she's just being a wimpy teenager. She's complaining about her fever, whatever. Let's get a film." And it turned out she had this huge, complicated empyema. She actually had bacterial pneumonia. It wasn't H1N1. And, we weren't getting x-rays on everyone that came into the ED. But I
Sure.
think if that nurse hadn't alerted me to like, she was able to pick up on like, this thing is not like the other.
Uh-huh.
And had we discharged that patient, she could have very easily had respiratory
Mm-hmm.
decompensation at home
Mm-hmm.
and ended up even sicker than she was, which
Yeah.
included an ICU admission and I think drainage of her empyema. But that nurse knew, like,
Yeah.
I'm not writing a text, I'm not paging, I'm marching into the workroom and saying like, "We gotta go see this patient right now."
Yeah.
So
Who's got
um,
this bed? Let's go.
yeah,
So
and I'll just remember that because it was that example of you see the same disease over and over and over
never.
again until you see the one that isn't that.
You're
And
totally
she
right.
probably greatly impacted the care of that
Sure.
of that
Sure.
teenage girl.
Yeah, and anyone who works in any sort of pediatrics, you'll come to hear respiratory season, where we just have all the respiratory viruses all the time. And you're right, it's the same thing over and over until it's not. So bringing back to trusting that gut, whether you're a nurse or a physician, you will develop that gut instinct. It will take time, but when it's telling you something's wrong, go up your chain of command. So you bring up something interesting that I had tucked away. I kind of wanted to ask about. You said, she didn't text, she didn't page, she didn't email, she walked into the workroom. So you highlighted a few different ways that nurses can contact, communicate, collaborate with their physician counterpart. And this is going to look different at different facilities with whatever technology you have going on. But talk to us about your experience with those different modalities, and what are your tips for deciding, hey, I'm marching into the workroom versus you're like, this is an FYI page.
Yeah. Man, this has changed so much over the last couple of years as well. Cause I've been there carrying like 3, 4 pagers on my hip as the night admitting senior, to now phone-based secure paging apps, to now the dreaded Epic Chat, which
Epic
isn't supposed
chat.
to be used for urgent things, but sometimes is. So this is part of I didn't learn this in nursing school. I didn't learn this in medical school. The sort of intricacies around communication. Again, with the caveat that I work in a closed environment, that being an ICU where typically the physicians are kind of co-located where the patients are, or at least in an office down the hallway.
You're nearby-ish, yeah.
We're nearby. If it rises to the level of concern where, say someone's been notified, there was some follow-up, the situation either hasn't improved or has gotten worse, or there's a new concern. I think with all of the web-based paging stuff we have, we forget how easy it is to pick up the phone and just say, I have a question about this patient, please call. And a lot of context can be lost in text. So I think, I know of situations where a nurse was really worried about a patient, and the words of the text, that urgency was not conveyed to the APP and therefore not to the physician. And in hindsight, it was like, I should have just called because I didn't describe what I was trying to say well in words. So I think if you are really worried about your patient, it's important to pick up the phone and have that conversation. Or in my case, just come find us. I've always tried to be somebody present on the unit, after rounds. I think we all kind of fall into that trap of the most face time is in the morning when we're doing our work rounds, and then life gets busy with meetings and other administrative duties, but trying to be present so that, again, it's all about reducing barriers. If the nurses know that, like, hey, Dr. DeMeo tends to be around,
Right.
therefore, like, he seems busy, but I know I'm not bothering him.
Right. And
They're
it
more
builds
likely
those relationships too.
yeah.
Like you said, you've worked in the same unit, you've gotten to know those nurses. So that kind of reduces the like, okay, I'm not nagging him, I'm not bugging him. He knows me. Like we have a collaborative professional relationship where you can trust them, they can trust you. So I mean, and you're not going to get there over text. None of us
Right.
build relationships over text. It doesn't convey tone and urgency, like you said.
Yep, that's right. And it's tricky because in some ways our lives have been made harder because there's so many different ways to communicate amongst the
Yeah.
healthcare team now that I worry that sometimes there can be like a diffusion of responsibility.
Uh-huh.
There are many things that are good about the team-based nature of our care, but I've found it hard on the receiving end to sometimes weed out what is just an FYI versus, what is, oh, I need to act on this. This is a problem.
Right. I personally have had a hard time with the chat-based tools that are like integrated into your EMR. For me, they just kind of tend to get lost in the shuffle. Like if I'm caught up in a busy situation, I'm probably hands-on. Maybe I have another nurse helping me document, but a lot of times I'm documenting after the fact. That's just how life goes. So I'm not necessarily like in Epic ready to chat somebody or keeping up with those messages. If I've got I think a big responsibility from the nurse, I always think about myself as coordinating, like running quarterback for all of the different services. So thinking back to my NICU days, I would often have, if I was working a day shift, like speech wanted to come feed the baby for their 9 o'clock, and then OT for the noon, and then they were going to get this, that, and we had a trip to the CAT scan at some point. And like the timeline and coordination, there would be so many people chatting about this, that, or the other. And it really can fall through the cracks if you don't have a good process for like, where are these messages going to fall? Because most of the messages won't actually be urgent messages. They'll be more the day-to-day things that you as the nurse, like you do have to keep up with. That's part of your collaborative effort.
Yeah. And, to be clear, I think I have an appreciation for that Herculean task that nurses have in organizing their day. And I've seen those cheat sheets that folks like to prepare with this, just like it's the itinerary of their day. And,
Yep.
I know NICU nurses are a funny breed. They'll joke
Mhm.
sometimes that they'd rather have the one on one patient who's on the high frequency vent with multiple drips because it's just, it's that hour by hour situation versus the logistics of trying to coordinate care times for three babies that are PO feeding at every care
Mhm.
time. And like you said, speech and family dynamics. So, yeah, it's a skill that I don't have and that I'm always in awe of when I see nurses do it well.
Yeah. And it takes some time to kind of figure it out because you also have to tweak that hour by hour, care time by care time, because things are going to shift. Speech got busy and they couldn't come. And then a meeting popped up here. We're going to have a family meeting or whatnot. So it's like you want to be structured and like have your whole plan, but then you have to be flexible enough to change it. I always called whatever my like cheat sheet was, I called it my brain. I'd be like, I set my brain down. Where's my brain? Because everything in my brain was listed out there for like what did I need to do that day.
And I think, we've been focusing a lot on kind of the relationship one directionally from, say, the nurse who may be intimidated by physician communication. But I think there's a lot of relevant lessons for new interns and new residents who actually walk into an environment where, in some cases, the nurse is the expert or has expertise in a different way than they have coming out of medical school. And I think it's another example where a little bit of kindness, a little bit of communication, a little bit of openness can go a long way because ultimately nurses want to see the new residents succeed and become good doctors and they want to see their patients treated well. I distinctly remember I had the pleasure of starting my residency on pediatric hemonc. That was my day one, week one of residency. I was covering the bone marrow transplant unit at AI DuPont. And I remember it's so funny. You still remember this stuff. I got a page about a patient who was like day plus 3 bone marrow transplant with a fever. And, I did good in medical school. I remembered my microbiology. I remembered my infectious disease and a little bit of my oncology. But I walked to that nursing station and said, okay, so room four's got a fever. And I'm looking and he's neutropenic because he's just had a bone marrow transplant. And the nurse very kindly, because I think I didn't come in guns a blazing, was like, yep. So do you want to get blood culture from the line and start cefepime and vancomycin? And I'm like, yes, 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 I
Yeah.
do. That sounds great. And of course I double checked everything, but I just found that ultimately if I came to it asking questions
Yeah.
and being kind and compassionate and communicative, that the nurses want to see you succeed as well. So interns, be nice to your nurses.
I love it. I think that that kind of bi-directional, like we are one team, we all want the same outcome. So it's just about how we're going to get there. It really does hit home. I mean, the nurses, like you said, we wouldn't be anywhere if we didn't have successful residents, interns, physicians, the whole nine yards. And the same goes the other direction as well. I think that it's very important to acknowledge that new providers coming in and asking questions of the nursing staff is, I think, a strength. I think very, very well received. It opens the door for that collaboration on day one. I can remember very, very clearly residents who did not want to collaborate and did not want to be a part of the interdisciplinary team. And then those that asked questions, talked to you, formed those relationships. And it really did just build a community that was so much more conducive to everything we've been talking about.
Yeah, and I hope that's changing slowly over time. I mean, you
Yeah.
and I in our day-to-day work with Archer are focused on nursing students and medical students and PA students, and I see in our medical schools the desire to bring interdisciplinary education into the medical school experience. And we try to model that for our medical students when they're on rotations. If you don't know something, it's okay to say, I don't know.
Yeah.
If you have questions about, especially in a highly specialized environment like the NICU, I tell the medical students, the nurses would much rather have you ask a question about, is it okay to examine this baby? How
Mhm.
do I move this baby with this line or tube? Could
Right.
you help me with XYZ?
Yeah.
Then have you just go for it. And I think as if we can start to build that idea that we're all swimming
Yeah.
in the same direction earlier and earlier in the training, I think it'll make that transition to residency not as harsh as it can feel for some
Yeah.
of us.
Not quite as stressful. Yeah, setting that expectation while we're still students. Because I mean, honestly, aren't we all still students? Aren't we going to be students for the rest of our lives? So, yeah, the earlier we start, the better. All right, well, I know we're coming up on time, so we've got a 3-question rapid fire exercise here. My top 3 questions that came in from our students, what they want to know for you, and we have a minute per question. Are you ready?
All right, let's do it. I'm ready.
Okay. First question, what is your top tip for using a structured communication tool like SBAR?
Okay. So structured communication tools. So SBAR, or you might use something like iPass. These are structured ways to give handoff to each other. Happens nurse to nurse, happens physician to physician. I think the one thing that is the most important overlooked component of any of these handoff tools is the anticipated course. So when you're handing off, we're becoming more shift based. You don't see interns doing 30-hour calls anymore, which is a good thing, but it means more handoffs. If your night shift is coming on and you've been taking care of a patient all day, you give them the situation, give them the background, and you're working through your whatever mnemonic it is. If you can tell them, and for tonight, I expect that we should not have any new fevers because we're now on a tailored antibiotic based on the sensitivities. If you get a fever, reculture and da 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 da. As much as you can give that anticipated course, I think we can eliminate some of those potholes that can happen in care when one person says, well, I didn't realize this had gone on before, or I didn't realize this piece of background. So both physicians and nurses and APPs could do well by adding that anticipated course or anticipation piece of all these handoff tools.
I like it. It comes back to right where we started with, fires might pop up. Where could they be? What would we do about them rather than just being super reactive? Love it. Okay,
Yeah.
question number 2. What is your top tip on how to navigate different personalities in high stakes environments?
Oh, okay. So I think we have to understand that medicine and healthcare is just a microcosm of the world. So we're going to have a cross section of extroverts, introverts, opinions, styles, and it's less about someone's personality and more about the behaviors. And I actually think diverse personality actually makes a stronger healthcare team because we can see each other's blind spots and biases. So I think if you're teaching, learning, mentoring, never give feedback on things that the person can't change about themselves. Like your feedback should never be about personality. It should be about the behaviors that are part of the external professional behavior of that person. So I think focus on the things that people can change and don't worry about the things that are just intrinsic to them and they can't change.
Yeah.
And I think
I
it
love
makes
it.
us a stronger healthcare team.
It does. It does. You're totally right. It's a microcosm of the world, and the variation in who we are and how we approach things can honestly lead to some really productive conversations. So embrace it rather than being scared of it. And I love the point about don't give someone feedback on something they can't change. If it's intrinsic to who they are, talk more about the outcomes of those behaviors so that it is conducive to this interdisciplinary collaboration. All right.
Yep.
Third and final rapid fire question. What is your top tip for confidently approaching a physician during rounds as a new nurse?
I think we already talked about it. It's just come prepared with the information about your patient. Remember, the physicians on your team may be responsible for upwards of 20, 30, 40 patients, whereas we're really entrusting you to know your patient inside and out. I may spend 10, 15 minutes at the bedside on rounds, whereas you're there for a 12-hour shift.
Yeah.
So just come with information, come with background, come with the context of what you're asking. So try not to report things in a vacuum. And I think ultimately that's going to lead to a more helpful communication for both parties.
Absolutely. And new interns, residents, new attendings coming to the unit, bring the questions to the nursing team as well. It's a two-way street.
Yep.
I love it. These are great takeaways. We really appreciate it, Dr. DeMeo. It's been a joy to have you sharing such practical insights so that we can collaborate with mutual respect and really get those patient outcomes that we want to see. So To all those new nurses, new residents, new everyone's starting out in the next couple of months, know that your voice matters. You have essential knowledge, observation, and instincts that you're bringing to the table. And when you work in sync with your entire interdisciplinary team, you're not just part of the team, but you're elevating everyone, including what we all want, our patient outcomes. So again, thank you to Dr. DeMeo. Thanks for tuning in to Pulse Check with Archer Nursing, and we'll see you next time. All right, future nurses, that is a wrap. If you found this pod helpful, I'd love to continue supporting your nursing journey through nursing school, the NCLEX, continuing ed, and beyond. Archer Nursing has you covered with on-demand video lectures, high-yield question banks, live case study reviews, and so much more. We want to help you master tough concepts and make it fun. So join us over at archerreview.com. Follow us on socials at Archer Nursing for more free nursing tips and study resources. Thanks for tuning in to Pulse Check with Archer Nursing. I'm Dr. Morgan Taylor, and I'll see you back next time.